We are here with Professor John Ayers, a data scientist and computational epidemiologist at UCSD. John, welcome to the External Medicine Podcast.
Thanks for having me.
Before we get started, do you have any financial disclosures?
Before working in academia, I did work in the private sector. Helped start a couple of companies that did data analytics, although no longer play a managing role in those.
All right. So we're going to talk about your most recent article on ChatGPT in JAMA Internal Medicine. But before we talk about that article, can you give a little sketch of your background and intellectual interests?
Well, I approach public health research from a different angle. Typically we have this top-down model where we, the experts, know what the needs of the public are already. So we can spend time designing studies and 5 and 6 years implementing them. And then everybody knows by then it's still relevant, of course, right? Everybody knew Tesla is going to be worth what it is now 6 years ago. It always works. I kind of reject that model, right? I say, what are the needs of the public and how do you listen to those needs? And so, we work in a public health surveillance angle where we try to use social media or other digital signals to understand what the needs of the public are. And then as new technologies evolve, how can we use those to respond to needs, which led us to ChatGPT.
Great. I was interested going through some of your previous work that you use Reddit a lot as a source for information. I was kind of curious how you decided on using Reddit so frequently as compared to like other resources where you can see what people are, like Google Trends, for instance.
Well, with Reddit, I think you get long form detail, right? You can see directly what people are thinking. In clinical research, we talk a lot about clinical outcomes versus surrogates. And when it comes to public health, we always use surrogates, right? We call them up on the phone. We tell them how bad it is to smoke. We tell them all these things about their health. And at the end, we go, you want to quit, right? And then 73% say yes. Why not 100%? Probably because the other 27 misunderstood the question in the first place, right? So we can directly observe what people are thinking and when they're thinking it. And Reddit is just one of the many forums that we use for that type of analysis. And with Reddit, you get this rich context. And additionally, we use Reddit because it's easier to analyze if you're starting out with, digital data analytics, simply because it's already aggregated around topics. You want to know about CBD and health, just go to Reddit RCBD. You don't need to build a classifier. You don't need to figure out what keywords to use. People are already telling you, we're talking about CBD.
And how much personal time do you spend on Reddit when you aren't doing these studies?
I spend zero personal time on social media, unfortunately. I just, to me, the venue I want to use to reach the public is with, rapid response research. We've been lucky in the last decade of my career to produce dozens of examples where research came out, weeks from when the topic was salient, and it can still have an impact on the outcomes. And so I focus on that venue. And I'm lucky in the sense that in my career, I can actually point to several studies where simply the publication of our study changed the outcomes. It's pretty rare in public health that we talk about. I do research to save lives, and it's very rewarding that, we've had some examples like with Charlie Sheen and HIV or Pokemon Go or to work on 13 Reasons Why, the Netflix series, actually made a difference in population signals.
Can you tell us a little bit more about when your research actually directly changed health outcomes?
Well, one of the first times it happened was with Charlie Sheen. And we all remember when Charlie Sheen went on the Today Show and disclosed he was HIV positive, right? And we all remember Matt Lauer asked all these public health questions. Oh, yeah, no, he didn't, right? He didn't ask about public health. He was interested in other things. And all the HIV advocacy groups, they talked about Charlie Sheen. Oh, no, they didn't, right? He was, they wrote in Hollywood Reporter, he had a sex dungeon, right? So let's not talk about him. But I remember sitting in my office and I was thinking, I'm like, man, this isn't 25 years ago. This isn't Magic Johnson. We've had decades where get tested, use condoms. We had this consistent communication angle. And so we used Google Trends to understand how people were seeking out information on HIV. And of course, information seeking was at all-time high, but specifically information seeking for HIV testing and condoms went up substantially, remained higher. It was the equivalent of many national HIV testing days. We published that study a few weeks afterwards. And when it came out, of course, it got a lot of attention. Charlie Sheen promoted our study himself. He appeared in a condom advertisement that we were part of arranging. And then the maker of OraQuick, I think the parent company is OraSure, that's the HIV testing kits that they use both in clinic and over the counter. They called us and they're like, John, we're going to get barcode data in like a week, and we'll be able to see how much actual testing cells changed over the counter. And my reaction to that was, yeah, I'm pretty confident our data is valid. I'm more interested in what the effect of our study. And so, Charlie Sheen talking about his HIV disclosure was the biggest event all time and driving people to do HIV testing. But our study, simply publishing it in JAMA Internal Medicine, was like the 11th biggest increase in HIV testing ever. And we didn't need, an NIH grant. We didn't need, to sit around and plan for 5 years to do that. Simply by hearing the public and responding to that needs and simply saying, we hear you, we could create an echo effect. And so a lot of times when we do research that has an impact on the outcome, it's often through that echo effect or through setting the agenda. With Pokemon Go, for example, we did a study on Pokemon Go when it first came out. I think we did a study the week it came out, actually. The week Pokemon Go came out, we did a study and we said, I know what I would do. I like to win, but I'm also fat. So if I want to get all the Pokemon, I need to drive around in my fancy sports car real fast and catch them. And I bet other people do too. And so we went to Twitter, and on Twitter, people like to do one thing more than anything else: tattle. And so we could see them tattling and saying, my mom's driving me around to catch Pokemon, or I'm driving around catching Pokemon, or I just almost get by a car because I'm running in out of the street catching Pokemon. And I think in the first week that Pokemon Go came out, there was about 370,000 tweets where people described a potential accident that they were involved in while playing Pokemon Go, either driving or as the passenger distracting the driver or as a pedestrian interacting with cars. And I remember where that we didn't need this top-down model. Niantic, the maker of the game, did not want to injure people, and simply getting our study out there and talking to advocates in the company, the game was made unplayable if you'd been at driving speeds. And so it set a precedent for augmented reality games to come, so that you don't play those games when it's potentially risky for your health. But luckily, we've had several examples like that, and I'm happy for it. I don't think it's anything we're doing that's special. I think it's just that we've kind of abandoned this bottom up, organic, getting the public back in public health framework. And by embracing it, I think even with simplistic studies like we're doing that, may seem like obvious, to hindsight, obvious at Charlie Sheen or obvious at Pokemon Go, but at the time, can have these effects because, we're not utilizing them. And my encouraging advice to people working in public health or academic medicine is to consider pursuing this, move away from the hypothesis-driven research to the needs-driven research. And, if we understand these needs and we echo that, it can have a direct impact on the outcome, and it can also potentially impact policy. And we see this time and time again. And hopefully that's true of our latest study on ChatGPT.
Well, that's a great segue to talking about your latest study on ChatGPT. So what was the background to deciding to do that study? And then if you could just describe what you did and what you found.
Well, the background there was, we're all familiar at work in academic medicine that doctors are fed up. They're tired of having a full inbox. Now we need more than just a medical assistant. We need a team to help us triage our in-basket messages, right? And so we're frustrated and we're complaining to the CMOs. And the Great Resignation wasn't just other fields, it was also medicine. Some people are leaving. I know several of my colleagues who, are practicing clinicians who went into concierge medicine simply because they were tired of the messages, right? They spent all day doing messages. At the same time, during COVID, we saw some rulemaking that made it allowances for you to bill for messaging. If it took a substantial amount of time, you could bill. And we've seen some organizations like UCSF start billing, and the effect of that was people started sending fewer messages because they get this warning you might get billed, and they're like, I don't want to do it. And then doctors, don't want to spend the time to do the billing because the routine of just doing that paperwork may take more time than even responding to the message. And I realize that's an important bottleneck, and I realize that doctors are stressed, and I certainly am sympathetic for them. But I look at the other side of that coin. There's 1.1 million physicians in the United States. That means there's 329 million patients. What about them? How many of those are getting responses to their questions? How many of those are getting high quality responses? And I know in our research, we see a lot of desperate help seeking. We did a study in 2019 in JAMA where we termed we coined the term crowd diagnosis. You've heard of physician diagnosis, self-diagnosis, crowd diagnosis, where people are going to public social media because they're so desperate for response and hoping a stranger somewhere will respond and give them the advice. And the case study we did in that study was people asking about STDs, and even taking pictures. You can imagine it's taking a picture and posting it to public social media and asking what that bump is. I mean, people in pretty desperate shape. And, we see that again with like other, question and answer services, that popped up in the commercial industry to service people, or even like, Reddit AskDocs, where you can post a question and see if a doctor will respond to your answer. 7 million people have used that service, and it's growing rapidly. The month-to-month growth is always increasing. And so that's kind of where we approached it from. And it's like, can we help alleviate the burden? Can we check the box of this could offer cost savings? But more importantly, can we help answer patients' questions? And with that, you would think like, okay, well, this is a great starting point. Okay, it's going to be really easy to do a study. And unfortunately, it's not. We don't talk about patient messages in healthcare. No one reports the response rate. Why would you? If you say your response rate is 70%, is that lower or higher than anyone else? No one's incentivized to disclose that. No one discusses the quality of the responses that their doctors are sending, these healthcare centers. And so instead, we used a loophole and we simply turned to Reddit AskDocs, where you can anonymously post a question and a verified licensed physician will provide a response. And using that, we then can have our study do 3 really unique things in this literature. The first one is real questions and real answers by physicians. I think this is the first in the literature, where you have authentic patient questions here posted to Reddit and real doctors responding on Reddit. The second thing we did is most question and answer services, they'll evaluate it by asking the person who posed the question if they're satisfied with the response. Why? It's easy. If you're doing a study, you can quickly see a question and see a response and ask them. But that's not really good for healthcare, right? Michael Jackson thought he had the world's greatest cardiologist. He thought he was so great, he told him to quit his practice and go with him everywhere, right? And become his personal doctor. And you saw how that worked out for him. So instead, we used licensed healthcare professionals, all actively seeing patients, and we asked them to evaluate the questions and answer 3 things. Which did they prefer blindly? The answer we saw posted by the physician or one generated by ChatGPT. Rate the quality of those responses from very poor to very good, and then rate the empathy. And that's the third thing we did. It's not just what you say, but also how you say it. And everybody knows that's ever been in a relationship. And so we asked them to judge the empathy from not empathetic to very empathetic. And what we saw is ChatGPT won in a landslide. 4-1, our panel of physicians preferred ChatGPT to physicians. ChatGPT responses were nearly 4 times more likely to be rated as good or very good in quality, and ChatGPT responses were nearly 10 times more likely to be rated as empathetic or very empathetic. And so it was a really shocking finding. We certainly did not expect that, to see that a large language model that was not designed for healthcare delivery, that was not tailored to healthcare data, and is certainly in the very, very early stages. We even used a version of ChatGPT that is now defunct, 3.5 version 1, which you can no longer even access. There's now, 3 iterations later. And so with that, it's kind of like, how do we integrate this in a way to help people? And hopefully that's where our study makes a difference.
So all of the people who were evaluating the responses were physicians?
Yeah, that's right. One was a nurse practitioner, but worked in primary care, seeing patients autonomously. But all were physicians and all had backgrounds in internal medicine with additional specialties on top, like infectious diseases or oncology, but all had that basic training in internal medicine.
Going into this study, what was your expectation of what the results would be for preference, quality of the responses, and empathy?
Well, you guys would know being a doctor is really hard, right? It's more than just watching Grey's Anatomy. It takes a long commitment and lots of study. And so the idea that a large language model would win was surprising. A lot of our annotators, they had, the opinion that there's no way. There's no way. I can destroy an AI chatbot. And by the end of the study, when we had the results, I remember one of our evaluators was like, this is a prescription I want to give to my in basket of messages. I can already see the value in it. It does better than me simply by seeing it in comparison to other physicians. That was where we approached it from. I think, one of the criticisms of our study, and I think it's fair, is, well, did the evaluators know which was which? We certainly tried to blind them. ChatGPT responses are longer, so maybe they could have figured it out. Or did the author team already have a decision that ChatGPT should win because that would make our study more publishable? And I would tell you no to both of those. I think we did the best that we could with blinding, and our physicians certainly wanted to win. And then, irrespective of what we found, I think the study gets in JAMA Internal Medicine. ChatGPT doesn't do well, it gets in JAMA Internal Medicine. If it does well like it did, it gets in JAMA Internal Medicine. So, the source of bias there, I think, is minimal.
The specific, something like just under 200 questions that you asked, there's obviously a large sample that you could have chosen from AskDocs. How did you actually select which questions to ask from Reddit?
We simply random sample. Our target was to have a random sample of 200 question and answer exchanges involving a physician. It was slightly less than that after some data processing and some errors in the way we collected the data, but we ended up with 195, and yeah, that's where we were. And I think it's important to not limit it, right? In this stage, we're trying to see, the denominator here is, can it answer questions that patients would ask? And so we didn't make any exclusions. Even when the patient was asking you to interpret an image, we kept that in the study, knowing that ChatGPT wouldn't be able to look at the image. Now it can, but at the time it couldn't. So clearly that would be a case where it would always underperform. But we kept it in there because we're like, this is a random sample of what people are asking. We don't want to process the data in a way where you can't walk away with that inference of, in general, the types of questions people ask. What does this look like? And also, our evaluators were very confident that these messages looked very much like the types of responses, the types of questions that they get in their in basket, and also the responses, except for, in our case, people was like, well, what kind of doc would sit around in their free time and answer questions on Reddit? Is this person even human? Right? I mean, who would do that? And so you could be like, well, maybe ChatGPT is just better than these Reddit docs. But looking at the data and talking to our evaluators, the responses typically look like the ones that they see their colleagues sending when they're asked to consult on issues. And also, the Reddit experience is certainly better than the experience in the real world. On Reddit, everyone gets a response. In the real world, maybe the modal outcome is non-response. On Reddit, the time to response is hours. And in the real world, sometimes you don't get an answer until the question is no longer relevant, 2, 3, 4, 5 days later. So, I would make the case that our results are probably would be even stronger, the benefit of an AI-assisted messenger in a healthcare center than on Reddit, which is a sad state of where we're at when it comes to healthcare and how we respond to people's questions.
In deciding what evaluators should evaluate the ChatGPT and the Reddit docs responses on, you chose quality and empathy. How did you decide on those two? And why didn't you also ask something like accuracy or plausibility or something else?
Well, we had 3 outcomes. I'll remind you, we had quality and empathy, but we also had which you prefer. And the preference, was again similar. 80% of physicians preferred the ChatGPT response. We started out with focusing on, is it accurate? Doing some pilot annotations with accuracy purely, but the results were not informative. I'll give you an example. A person might write in, I swallowed a toothpick. What do you think, doc? I'm pretty worried about it. You can tell they're anxious. They're writing this message like, I had no idea. And I was eating this kebab and I swallowed this toothpick and I think I might die. Can that be the case? And the physician writes back, no, don't worry about it. That's a rare thing to happen. Don't worry about it. And then ChatGPT writes back, I'm sorry you're concerned. I can tell you're really worried. And yes, there's a small chance. And here's the absolute risk based on my knowledge as an AI assistant of swallowing a toothpick. And yeah, you don't need to worry about it. But instead, you should worry about it if you have these symptoms, if you have really severe stomach pain, if you have blood in your stool, then you might need to go see. But otherwise, don't worry about it. It's a toothpick. Now, both accurate, right? Both, yeah, the risk is small. Both accurate. But which one do you think would be the message you'd want if you were sending that question? And clearly it was the latter. And so a lot of what you see when people were preferring ChatGPT, it wasn't because the doctor was inaccurate and ChatGPT was. Typically there was equivalent accuracy for a lot of questions, but it was more holistic. And I remember whenever I demoed this to people, I explained to them, yeah, ChatGPT doesn't know anything the doctor doesn't know and doesn't emulate emotions the doctor doesn't have. It's just not constrained. It can type 1,000 words a minute and the doctor can't. And you really see this even with simplistic questions like, and I encourage listeners at home right now to go on and tell a large language model, I have a headache, can you help me? And you'll clearly see why it's winning. It's going to be, I'm sorry you have a headache. The doctor certainly feels that way. They don't have time to say it. The doctor's going to respond back, have you taken over-the-counter medication? Maybe try acetaminophen. And he or she's going to sample over all these considerations they have in their training and come with that most probable response to give. Because he or she is limited in their time and their capacity to provide care remotely. Doctors did not sign up to practice medicine with a mouse and a keyboard, even though that's now how medicine is practiced. And so that's the response you get. From ChatGPT, without those constraints, it can be, oh, have you been staring at your screen a lot? It could be eye strain. Relax your eyes every 30 seconds. Are you dehydrated? Maybe check how much water you're drinking. Sleep is also important. Try sleep. You might try a mindfulness exercise and relax and close your eyes. Or you could try a warm compress or a cold compress. Some work for some people and some work for others. You might try over-the-counter medicine. Acetaminophen, it's called Tylenol. Follow the directions on the label. You might also try ibuprofen. Follow the directions on that label. Here's some brand names for ibuprofen you might want to look out for. And so it can just really give you that background. And once these technologies get access to the medical record, then the disparity between the responses is going to grow. A patient who writes in, I have a headache and I'm feeling dizzy and lightheaded. If it can look in the medical record and be like, oh, are they taking their antihypertensive medications? I see they're prescribed one. You might want to bring that up. Have you been taking that medicine? And that's going to be the game changer. Is doctors will be able to spend less time on verb-noun conjugation and the drudgery of having to look through EHR and more time on providing medicine, providing healthcare, impacting patient outcomes. We're pretty, people are kind of think I'm nuts now. In 3 years, they won't think I'm nuts, but I really do believe that these technologies are going to not only improve workflow, but actually change population health outcomes. And you could make an argument for why we should be doing randomized controlled trials now in certain populations to measure that effect. And where this is the first time AI is more than just non-inferiority, it's actually going to be something that changes, feel, function, and survivability. And I'll give you an example. You consider heart failure patients. If you have a newly diagnosed post-MI heart failure patient, I know what the 5-year survivability of that patient is. I also know it's substantially reduced if they don't adhere to clinical advice when it comes to diet and exercise. I also know it's reduced if they don't adhere to taking medications as prescribed, they don't monitor the progression of their disease and come back to the clinic so their therapeutic regime can be modified, as their disease progresses. Messages can directly impact those outcomes. And messages can become more than just an AI assisted messaging can become more than just handling the inbox. It can become an outbox. Now we can directly reach out to people with, personalized messages that, are tailored to you to help you as the patient compared to the methodologies we have now, which is, smart phrases on Epic and sending some canned message or, some canned message that comes straight from the CMO's office about like COVID, like we all got 500 of over the last 3 years. And I think, this could be a game changer for those patient populations because now millions of people are out there desperate for answers, searching online. If we integrate this technology into healthcare delivery, it means they come to us first. people are going to use these technologies with or without us. They use Dr. Google without us already. They're going to use AI assistants without us unless we integrate it, unless we make that workflow, unless we prioritize them as their health outcomes as the achievable aim of what we do in healthcare. They're going to do it on their own, not do it with us. And if we integrate it now, then that's a game changer for population health, because they're going to come to us with these questions instead of just whatever happens to pop up over the next 2 or 3 years.
So I had a few questions while reading this study. It would be pretty difficult to confuse me as to whether I was reading a response by ChatGPT or a real doctor. I mean, especially factoring like abbreviations or capitalization or sentence structure. It's just obvious to me that if something is perfectly written, it wasn't done by a human. And so, but then that got me thinking, you know, you could train the GPT on all of your previous messages so that it can actually write more similar to you. And then that problem goes away because it's going to sound exactly as you sounded in the past, but just have more, you know, empathy or whatever that goes with it, or additional statements of concern. And then the question is that if you do that, and the person doesn't know whether they're communicating with a bot or with a physician, is there any sort of moral question around deceiving someone, or does it not matter because it's trained on all of your work previously and you can click a button saying like approved at the end of it? Anyway, those are just some of the thoughts.
That's an excellent thought. And I'll answer your question in 2 parts. So one, yeah, you can tell it's a bot. It doesn't make mistakes. The responses are longer. I'll also say we did a sensitivity analysis, and even when physicians wrote long responses, ChatGPT still did better. It still was preferred more often, and it was still had higher quality and empathy scores. In terms of like, how should patients feel about this? And a lot of people ask me about this. They go, "Oh, this icky feeling, my doctor and AI, I don't want that." I think the feeling of not having your voice heard and non-response, which may be the norm now, is much worse to patients. Patients want to be heard. Secondarily, this doesn't differentiate from the way we handle messages now. You know, most physicians have a nurse that handles their message in basket and will, you know, triage the basket and, you know, draft responses, even send responses on the doctor's behalf. Sometimes we actually have teams that handle messaging for, you know, heavily impacted specialties like primary care, where a whole team managed by a physician assistant is managing messages for the whole clinic. Right now, you know, if you get a response yes or no, it's kind of luck of the draw. If you get a good response yes or no, it kind of depends on if a brilliant nurse wrote the response, or an average nurse, or a below average nurse wrote the response. Now, I think, you know, with AI assistants, you know, our goal is not to replace the humans in this loop, but it's actually to elevate, and as a starting point, everybody gets a strong message starting point. And then that same team that's doing all this labor on respond, don't respond, triage it is an emergency, not an emergency, can then spend those resources elevating, correcting, enhancing, tailoring the message based on the EHR, where these technologies now may not have access to that information, and then sending that message. I think, you know, that's certainly a game changer. Right now, I don't think that there's any evidence, although this hasn't been studied, to say that, you know, the way who responds is really bothering patients now. Is it their doc or their PA or their medical assistant or a nurse? That doesn't seem to be. It seems to be most people care about not getting a response, and that should be the outcome we focus on. You know, not those icky outcomes and not those workflow outcomes, but our patients around 5 years from now, more so when they have a physician working with an AI assistant versus just a physician, and we can answer those questions. And if that's the case, then implement it. If it's not, then maybe don't.
Yeah, it seems to me there's some sort of category difference between when you're speaking to your physician as you would to a friend or a mentor or someone who you want to really hear where you're coming from, and, you know, typing questions and just looking for like, look, based on my test results, what does that mean? What are the next steps for me? And I think, you know, certainly there are times when I want to be heard, and there are other times where I just want correct information as quickly as possible. And I don't always need someone to throw in an empathetic statement of some sort, just to make me feel heard if all I want to know is what is my LDL being over 200 mean and what should I do to try to fix that?
Yeah. Yeah. And we certainly see that certainly could be the case. We'll have to see, if in the long run, what attributes of messages are predictive of changes in patient behavior and patient outcomes. It may be empathy is less important than what we're thinking now, by making it one of the three primary outcomes in our study. But, I think, having implementing it now, we'll be able to see pretty quickly, what attributes matter. And certainly it can do a better job for, like you said, these types of like discrete questions people have. We saw that a lot in our data where people would wear like a Holter monitor, or they'd have some panel of labs and they want to know, 210, should I be on a statin? What do you think, doc? And right now they're getting a canned message, if they're working in Epic using smart phrases, or, no response. And at least this is more tailored. And you could see in some of the questions people were asking, they were literally already talking to a doctor and they did not understand what the doctor was talking about because the doctor was so, curt with them and just said, copied and paste whatever the lab result were, or the results of a Holter monitor, and pasted it into response and sent it to them. And they're like, what does this mean? And I remember one example where someone was wearing a Holter monitor and, their physician had literally just copy and pasted the interpretations of that Holter monitor. And then they asked on AskDocs, and the doctor on AskDocs went completely normal. That was all they said. And then, ChatGPT was explaining like, a PhD, yeah, this is pretty common. You drink a lot of caffeine. This is not this is not something to be worried about. This is completely normal, but this is what it means. Maybe sleep more, and watch your caffeine intake. Otherwise, you're lucky. You have no problems whatsoever. And with this particular diagnostic, and that was certainly preferred.
I want to talk a little bit about the public response to this article. We both listened to your podcast on sensible medicine, in which you talked about ChatGPT. I'm curious, what have been some of the more common praise and criticism that you received for this, and what do you think some of the most interesting things that people have brought up have been?
I think first, we've noticed that there's a lot of focus on these secondary. I consider them secondary issues, and that's my opinion. Of course, opinion is a reflection of data and values, so this isn't an empirical assessment. But like the icky feeling that patients have, or do we want to integrate this? Shouldn't we be doing studies on like how it makes patients feel? How do doctors feel if they use this? And I'm a little surprised by that. I always thought, clinical endpoints were more relevant. I thought we did the necessary study, and the findings of our study are strong enough to do clinical endpoints, to do randomized controlled trials and implement this technology and see what the impact on patients are. The other thing that surprised me is how little talk we have about why messages haven't been addressed. That's a regulatory science issue. We don't emphasize patient outcomes. Regulators do not say you need to be, healthcare centers are already implementing this. UCSD, there were some very nascent pilot studies on using this technology within Epic, technology as provided by Epic with Microsoft. This technology could easily be implemented simply because it makes doctors' workflow better, and we can maybe fire some nursing assistants who are doing messaging, and it's a win-win for everybody. I don't view it that way. I view it the way is like, how's it going to impact patients, and how do we incentivize that? And I think there's ways we can incentivize it. And certainly, EHRs have to be certified. That's one rulemaking. Rulemakers are worried about delaying the development of this technology. They don't, they typically use stop signs and guardrails, and they're worried about putting those up because they don't want to delay the development. I think they could also be proactive and set goal lines. And one goal line they could set is, you cannot implement AI assistant messaging into a certified EHR for your patient populations until it's demonstrated to have improved patient outcomes. If they did that, there would be 1,000 randomized controlled trials registered tomorrow. and the conversation would totally shift to patients first. Hopefully, our study, by pointing that out, will encourage that. There's also been other reactions to our study. I think it's a common reaction I have to a lot of my research is, well, John's just playing show and tell. Well, when you got something that may work and may help people, and it's pretty obvious how and why, it doesn't take a complicated bunch of science and mathematics to demonstrate that. You can do something really simple like we did. And the really simple method is sufficient to make a confident assessment about whether we pursue these in more robust, clinically oriented studies going forward or not. And we certainly proved that point with our study.
One of the interesting points brought up on sensible medicine was the issue of accuracy. And I think it's an interesting question because there's a lot of variability in how physicians answer questions. There's a lot of, we don't even know how much variability there is. I think they've done some studies on this and like radiology, how often something is called as, X or Y or Z, and then trying to compare that with like pathology on that particular thing that they then investigate. Are you familiar with Daniel Kahneman, the psychologist? Yeah. So he's written a bunch of books on bias and different cognitive biases, but his most recent book was on noise, which bias would be mistakes that always fall in one direction. You can expect people who like the availability bias is the classic one, where the vividness with which you can bring something into your head ends up being a substitute for how common or the probability of that occurring. So that's something that's well researched. On the other side, you have noise, which is that depending on the time of the day, people will make different decisions. I don't know if it's apocryphal, but before lunch, more people get more time in prison than after lunch or whatever it is. It just depends on a person over the course of a day might make different decisions depending on all sorts of factors. And then there's within a person over a period of time, and then there's between different physicians. So I see ChatGPT as a way to not always get the correct answer, but use the wisdom of the crowd to get a more consistent answer for any particular issue. I don't know if you have any thoughts on that.
No, I certainly think that's the case. Clearly, one component of healthcare delivery are these, flow charts, and some people rely on them and some people don't. I think, since we're talking about VP, I know my friend Vinay would certainly tell you never use the flow chart, right? He knows more than the flow chart. But it's, I certainly see it as like providing the more typical Ming response, and certainly potentially correcting for errors. You brought up first accuracy, and while we didn't specifically annotate for accuracy simply because, it was, and our data is public, so anybody can go to Dataverse and download our data. That's the other great thing about the work that we do, is we always make our data public. That's pretty unusual, unfortunately, in medicine. And in social sciences, they have this replication crisis, and in medicine, we don't even know if there is a crisis because you can't replicate anything. So fortunately, the listeners here can immediately go to Dataverse and download the data and replicate our study in its entirety and enhance our data. And they could evaluate specifically for accuracy, but certainly accuracy was a subcomponent of quality and obviously a subcomponent of your preference of ChatGPT versus the doctor. And, we originally, because remember, I'm not that kind of doc, right? I'm an epidemiologist. And so I remember my initial knee-jerk reaction was, oh, I've seen Catch Me If You Can. Maybe one of the outcomes should be, I concur. Do I concur? And once you start doing concurs, at least when I was looking at the data with, a different group that wasn't our annotators that we used, but just to pilot, what I was going to ask our evaluation panel to look at, it just turns out they concurred to everything. I agree with all these outcomes. They're all equally accurate, right? Like, that halts are completely normal. I concur, and so how do you, and I think that's why we ended up with quality, and it will be seen. I don't think our study, though, is an interesting point to think about. I don't think our study is replicable today by end users simply because, trust and safety teams at OpenAI have changed the responses. If you're using 3.5 Turbo or 4.0 ChatGPT, and you put in these same questions, obviously there's randomness to those large language models. You can fine tune that if you use the digital playground for programming ChatGPT, which of course is what we use. But you get a response of I can't provide healthcare. I'm not going to, and that's concerning because I think we need these public tools to be accessible to researchers to evaluate and improve. And I worry about that. One of the reasons we always make our data public, and in this case also, is so other people could build on it. And I do worry about, there being this inability to build on it. And I also worry about, potential, monopoly type companies operate in this space where, if you happen to be at a healthcare center that uses Epic, that's typically going to be academic medicine or a large urban area, then maybe they have the resources to partner with Microsoft, and therefore you get a good LLM. And if you're on like Allscripts, then, maybe you get the equivalent of what Siri is today, even with the same technology, which is not good. And so I worry about that too. I don't know if I answered your question entirely, but I think that's what you're getting at. And I think the idea of wisdom in the crowds too is like we know about prediction markets. And that is if you sample over a lot of people, even with things that require expertise, you get more reliable and accurate answers than you do even from constraining your answers to, a single very, 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 very educated expert. And I certainly see that's how ChatGPT would work here. There's potential to train a large language model and fine tune it around something like up to date, train it around high quality examples of patient provider interactions. Maybe we could use public data like on AskDocs and have staff enhance the responses even further, who themselves are clinicians, and use that as training data. There's a host of ways to really train this. And I think when you train it, what you're going to see is really that's what it's doing, is that sampling framework and both how it presents all those considerations that it's sampling over, and then the most likely outcome, is different than what physicians do, where physicians just go to, what's the most likely outcome here? I'll just say that and move on. Not that that's necessarily wrong. It's not, come back to accuracy, but it's certainly not. It's certainly of lower quality typically.
I really like your idea of actually empirically testing how ChatGPT would work in a real use case. So the example you gave of like heart failure patients and, having people have access to either ChatGPT responses versus either ChatGPT overseen by a physician versus just physicians themselves to see if there's actually a difference in outcome. Because what I've most heard people say in hearing this data is one of two things, which was kind of perfectly modeled on the podcast you had with Vinay Prasad and the Sensible Medicine folks, which was either Vinay Prasad's claim that he would be better than the algorithm, or alternatively, sort of Adam Sefew's claim, which is, if this is better than me, then I would stop being a physician. Like I don't see a role for physicians in the world where an LLM has more empathy, has higher quality than me. And I mean, both of those claims, I think, are potentially empirically testable in specific use cases. Aside from the heart failure example, are there any other specific areas that you think that this could realistically be tested for outcomes?
Yeah, I think you can look at all sorts of chronic illnesses. You can look at like HIV positive. I'm an infectious disease epidemiologist. You can look at, HIV positive diagnoses. You could look and see if, AI assistant messaging, in this case, increases adherence to art, and then also if it reduces, transmission rates, among those people as they transmit it to other people, because obviously if they're taking their therapy and they're disclosing their positive status and, engaging in less risky behavior, then the risk of transmission goes down. That would be a clinical outcome in and of itself. You could also look at cancer patients and cancer patients who are put into, who are either in remission, and then we can potentially discover when they're out of remission sooner. With this technology, we could be asking them to monitor their health, to monitor symptoms. We could automatically come back and talk to them about it instead of waiting for that once a year to come in and get a physical. Also in primary care, I think a lot of what we do in healthcare is primary care related, but also it actually is important patient outcomes. I remember we did a study once on CBD, and some patients were saying, "I stopped taking my Coumadin. I have AFib. Taking CBD now instead." That's definitely going to be bad for their health, right? Their risk of stroke is now substantially higher. Messaging can fix that, even in that patient population. And a lot of things we think of as PCP is not, related to these dramatic endpoints are, primary care, is really the interface by which specialists communicate to their patient populations and manage their care for chronic conditions, or episodic acute conditions. And, that's going to be the game changer. And I think even in a primary care setting, you could probably observe some clinical endpoints. It would take a much larger study, of course, because, with like heart failure, I could use I could use mortality as the outcome. With HIV, I could use transmission as the outcome, or viral load as the outcome. But with primary care, with a sample large enough, you might see it. And, surely we do see it, right? We work in healthcare, and, people have this reputation as this is this guy's the expert in HEMOC. This is the one you want if you're sick. And anecdotally, people see better patient outcomes for that physician. And, maybe a portion of that is not just their clinical skills, but also their communication skills, even though we don't ever observe it and test for it. And the portion of that is communication can now be given to everyone with an AI assistant messenger. Also, I think it also changes the way people interact with healthcare. And I think this is a point that people don't talk about much, but it's just as important. And that is, we don't want our urgent cares and our ERs full unnecessarily. AI assistant messaging can prevent that from happening. AI assistant messaging can mean that when people come in, it is an emergency, we have the resources to treat them. AI assistant messaging also means for our primary care populations that we monitor their health. Someone who has a PCP that's also a patient of cardiology, like with AFib, that we're monitoring their adherence, to blood thinners, or if they're doing, rhythm control, we're monitoring that as well. So, there's a host of things that we can be monitoring with these chronically ill patients. I don't know summary. Maybe John Ayers has done this at one point or another, but I don't know summary what is the risk in terms of health outcomes for noncompliance. And I don't think we studied it potentially, because if you study it, what are you going to do about it? We want to see them once a year anyhow in PCP, or we want to see them once a year if they're, chronically in, a cardiology patient, or if we need to do a procedure, then we'll see them again. I don't know what the effect of noncompliance is, and what if that effect is. It could be ameliorated with AI assistant messaging, and we could certainly do better with our resources by triaging people in a more systematic way so that the ER is less inundated. And, that's what I see a lot with those AskDocs questions is like, people are kind of like, do I need to go to urgent care? Yes or no? That's what they're looking for. In a lot of cases, not all the cases, but a large fraction of the cases. And certainly this would be great for that. I also wonder how you stand this up. Here in America, we have this for-profit healthcare system, and what's that look like? In the UK, I could see, the NHS has been doing large pushes to make more access to primary care. And that's been a big push. A lot of people do not have annual access to primary care, because of waiting lists or just the geography of where you're at. If you're in Hampshire, you may get it. If you're in York, you don't. And so, one of the things that systems like that could do is stand up like a freestanding instance of an AI assistant messenger, manage it separately to any individual healthcare center, and then it becomes a public good. It would be a public good for everybody. And then part of what that AI assistant messenger could do is referrals. Refer you to the healthcare center at your place in appropriate healthcare, urgent care, or PCP, depending on your needs. It can make those referrals. And how do we do that in the United States? I could see like Mitch Katz up at New York City Health and Hospitals doing that simply because of the size of his patient population. But that's really something all Americans would benefit from. And how do we make that possible for all Americans?
So you're sort of advocating for a much larger role of LLMs in healthcare. And, I definitely can see the use cases for it. I know for myself, I have used UpToDate religiously since becoming a doctor and even before becoming a doctor. And there are some questions that it just cannot answer the way that it's set up. And using the latest rollout of Bing, for example, a question that I recently asked it was, what is the evidence for albumin? Like sometimes when you can't give someone fluid and you want to get their blood pressure up, and everyone says, oh, it just lasts, 5 minutes or an hour. And then some people, like the renal department where I am, they're really a huge fan of using it all the time. And I just wanted to look at the original studies, like how did we come to use it, colloids versus regular fluids. And the answer that I got by Bing was just with references was much, much better than what I got from looking something up on UpToDate. I can also imagine the other thing that comes to mind is since the introduction of AI and chess has been cracked. Like we know now that Magnus Carlsen will never beat the best AI at chess. And the question is, what happens when AI is better than humans in a particular subject? And with chess, we see a few things. First of all, interest in chess is at an all-time high. And the second thing that we see is that afterwards, people got better. Like you see people performing better. And I wonder if there's a similar prediction that we could make in medicine for a larger role of LLMs in healthcare, that people get better at being physicians, patients get better at understanding their diseases, and we could level up everyone, if that makes sense.
Yeah, exactly. So, I would say there's clearly, instances of how you'd use this and how, AI is going to make doctors better, but it's also going to make, training regimes better. We could use, AI assisted messaging as a tool to train doctors on, patient communication, via text. In the future, we'll be able to do it with voice as well. And we can actually make doctors better communicators because we have LLMs. We can also use LLMs to make a way to search and seek the literature. I remember the last time The Economist reported on it was the volume of publishing, in the medical literature. I think we were up to like 2.5 million articles a year, and that was 7 years ago. And then during COVID, everybody became a COVID expert, right? And so you had all these articles everywhere. And it's like, whoa, how do you synthesize that? And, how do people keep up with the literature? And I think LMs can maybe help us with that. Whereas now the way we engage with literature is kind of episodic. We see that JAMA internal medicine paper everybody's talking about. And then when we just happen to look something up, we look up something, we find this one paper, and maybe that one paper is total garbage. Maybe it's just, multiple hypothesis testing bias, right? Maybe it has, really bad design. Maybe it's never been replicated. Maybe it never will be replicated. And it's not an indicator of any central tendency, in that literature. LLMs can help us with this as the literature is growing, resolve and identify that central tendency and identify it sooner, almost like a meta-analysis does, but, it's doing it in a different way, not through classification, but through, dissecting and understanding the language. I certainly see it playing a role definitely in those ways and how we synthesize information. And I don't think with these roles, there'll be a negative reaction from doctors working in healthcare, like there might be for the potential of it augmenting actual healthcare delivery. I think there's more openness to having it, be the next Google Scholar and, being the next training aid when it comes to communication. Having just seen, the messages we saw in our study, and, I looked at every one of them, and I reviewed all the, responses. I was really interested in this, and I'm like, man, I bet I'd be really good at drafting a good message now, just from looking at 250 examples. And it's going to have collateral consequences in the way we communicate in other settings. It's certainly, I think so. But my emphasis on healthcare is simply because I want it to impact patient outcomes. And I think, that's where it's going to impact patient outcomes, is in the healthcare setting. And I believe that's where it's going. I mean, I'll make the prediction that's going to be integrated in some EHRs within the next 3 years. Do we implement it in a way to discover the benefits and maximize those? And do we do it in a way where we can discover the harms and minimize those? Speaking both of those to patients. Unfortunately, maybe not, because the incentives aren't there now. But if we make that the end goal, I think it could be a real game changer for health. I'm pretty optimistic. I think our study hopefully would be looked back on as, starting this important conversation that even though seeing the study, people are kind of like, yeah, this is obvious. And a year from now, people are like, no, duh. But I think starting that conversation now is going to help accelerate this and make a difference. You asked about reactions. Well, you can imagine I've gotten scores of emails from venture capital firms who are eager to implement this technology. I'm not the person to do it. I've never taken VC money in that way or been involved in that way, but clearly there's an appetite among investors that they see this as a future, mainly because, if you did studies like I suggested, and you showed that the message itself directly impacted patient outcomes, you could do more than just bill for physician time. You could bill for providing the service. UCSF bills $75 for private insurers for every patient message they respond to, that that the doctor also does the billing for. Their billing rate is low, of course. But if you had this, and then you could bill for this and improve patient outcomes, then that bill maybe goes up to $120. And then it's a no-brainer to do messaging. I think there's going to be a huge push from industry for that reason, simply because the money's already there. I'm more agnostic to that. I grew up in a trailer in North Carolina, up in the mountains. And so, to me, my outcomes are always the patients first, because I know what it's like to always be the patient that's last. Is at the back of the line that doesn't have a good doctor, doesn't have access to healthcare. My dad had mitral valve prolapse, and his disease progressed and got worse until he went into, very late stage heart failure before he could get his surgery, simply because we were poor. I think that outcome represents most people, unfortunately, who are patients. We forget that because we live in an isolated world where we work in academic medicine. We're all filthy rich. I never assumed I'd be as rich as I am now, and that's the norm. I'm not an outlier. It's a very lucrative field to be in. And too often we forget, because of that reason, we prioritize cost savings when it comes to healthcare or monetization, and too little patients. And so I certainly think if AI system messaging was available to me as a kid, I would have benefited from it. And a lot of my contemporaries who did not go into academic medicine, they would benefit from it now. And that's really why I advocated for it in this way, and not because I know it's going to be a benefit. It could not. And, that's important to do those studies now rather than implement it and get into a place where we have to do medical reversal. And then how do you get this out of the system if it doesn't do any good? Or clearly it could do good. Let's implement it and figure out a way to maximize that.
I share your overall optimism about LLMs in medicine, but I think your last point is well taken, that my two main concerns about the use of this technology are, one, that knowing more is not always better. Being able to detect the cancer even earlier before a regular radiologist would might lead to more procedures, which lead to more complications, which actually worsen patient outcomes. But in this push to just do more and better and know as much as possible, I think that we may lose sight of that. So that's one issue I could see. And the other issue is actually the technology being co-opted more for liability purposes than anything else, like sending more people to the emergency room. You know what I'm saying? Like sometimes you ask.
Yep. Defensive medicine.
Defensive medicine. Exactly.
Yeah, no, I think your concerns are founded, and clearly we need to keep those in mind. And it could be there's other concerns that we don't know to vocalize now, and those end up being the major ones. And there's only one way to discover them, and that's through rigorous evaluation of implementation within randomized control trials. And either we do those or we don't. And it could be we end up in a position where all the benefit is never realized and consequences are realized that we didn't anticipate, yet we're still going to have it because it's monetizable. And that would be very unfortunate.
We have some rapid fire questions for you. So
Yep.
starting off is schizophrenia seasonal?
Well, there's a literature out there that'll tell you it is, but not because of increased incidence or severity in the patient, but because of their birth date. I think that's just the issue of we have so many people studying these outcomes that, what data do we have in the EHR? We have birth date, and that's it. There's not enough prevalence. We did look at that before. We looked at people searching for, symptomology across both AXI1 and AXI2 disorders, including schizophrenia. And we showed that there was seasonality in schizophrenia, as well as ADHD, bipolar, depression, anxiety. There's something out there, and that effect actually is amplified by daylight. The further you live from the equator, if you live in Florida, the difference between the peak and trough, summer and winter, is different than if you live in Boston, or if you live in Melbourne versus Sydney. It's going to be different also. We studied Australia in there. So yeah, there's something out there. I don't know what it is, but there's something out there that drives mental health. And it's pretty interesting to think about it. We did that study many, many years ago. And I really, over the years, kind of haven't gone back to it because, we did what was available. Can we figure out what that is and put it in a pill? But I've gone back to it a few times myself and looked at it and been like, man, what's some explanatory variables of this? Like if I look at a small town that has a medical school and a college, is the effect bigger because it's just a school driving it? And no, it's the same. It's always there, and it's you can tell by your latitude, the effect is larger as you move further from the equator. It's pretty wild. Never didn't expect to find that when we found it.
All right, e-cigarettes, unmitigated blessing or accursed plague?
Well, e-cigarettes, we're semi-famous for discovering that they're popular. I'll tell you the backstory. I think your listeners will like it. What made me do it is not because I'm a tobacco control expert, and I'm still going to answer your question, blessing or curse, but 60 Minutes. Leslie Stahl was famous way before she interviewed Trump, right? She was always on 60. She's been on 60 her whole life. I think she's going to be on there until I'm gone too. But she did a thing on snus. Have you guys ever heard of snus? Probably haven't heard of. I'm seeing shaking head no's. Haven't heard of snus. Well, there's a 60-minute story about snus and why. The NIH and the federal government was spending millions of dollars on this snus epidemic that was coming. It's like a Tic Tac with tobacco in it. You're going to use it. It's from Sweden. That's going to be the thing. And Leslie Stahl's talking about it. I'm thinking like, my Lord, I grew up, my granddad had a tobacco farm. I used to work out there in it. And I'm thinking like, I got this inside information on users. And I ain't ever heard of this thing. This is so weird. And so we looked and we showed that it was insanely popular, e-cigarettes compared to snus, like 60 or 40 times more popular than snus, even though everybody's talking about the snus pandemic. And it just shows this top-down model doesn't work. And it will go unnamed. It was a major medical journal we sent that study to, and it was a different editor at that journal now. I think we're 2 or 3 editors away from that. And I sent it, and the editor wrote back, it got rejected. And I remember I wrote to the editor, I'm like, I think, what are you talking about? 60 Minutes. They're saying snus, e-cigarettes. I've never even heard of it, but it's the thing everybody's into, and it's going to be the thing. And the editor wrote back to my emails pestering, and the editor said, well, I'm in a band, and I play gigs from time to time, and I never see anybody using an e-cigarette. And you're like, Jesus Christ, this is where our knowledge comes from? This top-down model where we're imbued as experts to know? And my answer is blessing or curse is like it could have been a blessing, but I think we missed that boat. There was some great reporting by Emily, I think Baumgart, if I'm pronouncing her last name correct. She was at the LA Times. She's now at the New York Times, where the Obama administration didn't want to regulate flavored e-cigarettes like Juul at the time was selling flavored e-cigarettes because that's the reporting. The White House thought this would be a great thing that we could sell to other countries, and other countries banned these products, and suddenly we just addicted our kids. And that was the end result, which is unfortunate. But yeah, the literature on e-cigarettes is really interesting. I think that I would move away from that, and I would talk about vaping, because vaping has now exposed people to a broad spectrum of drugs, including cannabis or CBD, and they're taking these other uses, and it's it's really changed the way people interact with drugs. Whereas we always thought of like cigarettes as this gateway. Well, now you vape one thing, you vape everything. I think we said it in a lot of the literature. And, all the kids vape and then they all vape everything. And certainly some of these things would be worse than nicotine. I like these. Let's go. Let's keep going.
Is suicide contagious?
Yeah, absolutely. That's well known beyond our study. You guys are econometrics fans. You'll know there's a famous econometric study where single occupant motor vehicle crashes that result in a fatality increase after celebrity suicide, and even single occupant airplane crashes increase after a celebrity suicide. We, not to say that these things push people over the edge, but people are already teetering on the edge and then they just kind of fall over, this idea of a pathway out. And, one of the more famous things we did in this area was on 13 Reasons Why, the Netflix series, and showing that when the show first started airing, it had this huge impact on suicide outcomes. Our outcome was internet searches, but you could see specific searches like how to kill yourself was up. And I don't want to give a precise number to imply that's the exact number, but it's in that range of like, I think it was in 25% relative increase. And other searches like painless suicide were up a similar amount. And you could see people, at the time of the release of the show, actually, potentially thinking of suicide. And I'll say in all the literature, talking about how to be a good doctor or a good scientist, and all the literature, the explanation for that was not as good as I heard from a celebrity doctor, Dr. Drew. Dr. Drew told me this, and I still talk to him from time to time still on other things and just periodically, but it was a really great insight. And that is, the lady was already dead when the show started. The opening scene is a memorialization of her locker. And there's a slow pan in. Yet there's a whole series about her. Her boyfriend really regrets mistreating her. Her parents love her more now. She goes to the ball or the prom and she's happier as a result. And Drew told me, and that's the way kids perceive suicide. I haven't seen that in the WHO guidelines, that they don't understand that death has this finality, that they think it's just one step in your life. And potentially that was one of the reasons that 13 Reasons Why had this huge effect, was because of the program mimicking how adolescents actually think about suicide, which I found very compelling. And I haven't seen a strong literature on that, but as a hypothesis, I'm like, damn, that's pretty good. I think we should look at that. But I also am sad about that too, because 13 Reasons Why was probably one of our biggest failures. Clearly we had a strong safety signal. We published that safety signal, within weeks of the program initially airing. And I think our study came out about 50 days after the program aired. We did our study, I think, 20 days after the program aired. It was pretty robust, compelling evidence. Sadly, our top-down model teaches us to reject evidence that doesn't come from this 5-year protracted NIH framework. And a lot of presidents of major societies, particularly in psychiatry and mental health, came out and said, whoa, what are you talking about? This is premature. Clearly, this is just starting a conversation. And I remember being on an interview with one of the morning talk shows here in one of the morning national talk shows. And you know how it is, guys, when you do it, you're wearing the earpiece and you're hearing what's going on. And I'm not your kind of doc, so I get upset and cry sometimes. But the person before me, his daughter had died, and he saw that the program was on the TV. Do you want to continue watching? Because she'd done it during the program. We really advocated to get that fixed. We failed. Unfortunately, I believe that failure is on us. But also, I believe part of that failure is because of that top-down model. A lot of people came out and said, whoa, this is just about a conversation. This is one study. We got to see this with other data. And yeah, JAMA Psychiatry ended up publishing a paper, but I think it was 646 days after our study where it showed actual suicides went up. And it's like, by then, who cares? And we wrote a really strong rebuttal. I'm sure I'll never publish in JAMA Psychiatry, where I basically said ignoring this costs lives. All we're doing at that point is putting italics on a CV the damage has already been done. And so for that, that failure, for me, has emphasized how do we attract more people to this perspective of bottom-up research so that we make a difference in people's lives, because I've seen in this instance where our failure certainly cost lives, and it's unfortunate. Next, more rapid fire. Hopefully we have a success with the next one.
All right, just a couple more. What is one medical truth that very few of your colleagues agree with you on?
I think it's probably going to be cannabis. I've been very concerned about the increase in cannabis use. I've been very concerned about how we don't regulate that marketplace. I think a lot of my colleagues go, it's just cannabis. Like, who cares? You know, they don't, it's only weed, dude. Like, even Barack Obama, he's like, yeah, it's only weed. And yeah, I think for Barack Obama, if you're a student at Columbia or you're at Harvard Law, a little weed won't have a big cost for you. But I think if you're in a trailer in North Carolina, I think that loss of competitive advantage in the world could shift your life off course in many ways. You know, no one associates using weed with increased productivity. You know, and I often wonder, like, if we did an econometric study, what would be the effects, you know, at the prevalences we're seeing now with these surveys, which in some states is pretty high. You know, we're talking as many as a third of people, you know, using cannabis. What's that effect on productivity? And when things like GDP predict all-cause mortality, which is partly driven by productivity, but also the fact that we don't regulate it. You know, I see the failures that we did with e-cigarettes, you know, not, you know, harnessing the potential of it to be a cessation aid and being potentially safe. Well, not being, is safer for smokers. We didn't do that, and we didn't protect kids. And I feel like over the last few years, we've done the same with weed. You know, we did published a couple of studies on cannabis, and one of which was an editorial. But I mean, we talked about a company called MedMen, and I mean, they're clearly advertising to kids, clearly using young models, clearly advertising it as a cure-all. And yeah, that's dangerous. I think I think these products, you know, should not be used as a alternative to evidence-based medicine. You know, especially when we have proven therapeutics that can ameliorate the suffering that patients have, or even, you know, prevent death. To see them move over to cannabis-derived products like weed or CBD is pretty concerning to me. And I really do think we have a blind spot to that. You know, we did a study for every, you know, what's the one thing we think about more than anything? How to lose weight. And there's so much demand for these products that for every 2 searches for how to lose weight, there's 1 internet search in America about how to get CBD. That's really troubling to me. It's that popular, and these cannabis-derived products are that popular, and that people are using them as a substitute therapeutic. You know, Scott Gottlieb testified before Congress speaking about these products, and he said, I remember the exchange. The senator asked him a question, was like, you know what, I don't want to say bad things about cannabis. It's a great drug. I'd like to hint, you know, get money from Clover when I leave here. My staffers probably work in the lobbying department. You know, that's you know, that's what's going on here. You know, Boehner is a huge lobbyist for this industry, the former Republican Speaker of the House. And I remember he asked a question to Scott Gottlieb, like, what do you think about this? And Scott Gottlieb was like, yeah, we're not that concerned. But if people used it, you know, as a substitute or alternative to, you know, evidence-based therapeutics, we would start to have some concern. And I remember seeing that testimony, and we immediately did a study on it. And we published that study some weeks later, showing that on these forums like Reddit CBD, that 90% of people who post that they're taking CBD are taking CBD for a diagnosable condition like AFib or like arthritis, and things where CBD is not demonstrated to be effective. And so they are. They're unnecessarily suffering and suffering longer because of this. And I just wish regulators would do more. You know, there's been a lot of concern about the supplement industry, but I think more and more that becomes a problem. And I also think part of the reason it's becoming more and more a problem is the way we talk about medicine now is black and white. You know, we've kind of lost all the nuance during COVID. You know, it's like this works and this doesn't. Well, that's not very evidence-based. Nothing we do in evidence always works and never has harms. And so the language we use to communicate products is very similar to what the for-profit industry uses for supplements. So it makes it very hard for patients to differentiate. I think if we had a more nuanced language, it would actually make us more attractive to patients, potentially.
Last question. If you had unlimited funds for a randomized controlled trial, what would you fund?
I would definitely do the AI assistant messaging. And I would do it on a high risk population, and I would do it with mortality as the outcome. That's because I think it settles the value add for this going forward. And I think this is one of the few times in your career where you can see this outgrowth of what could come from this technology, and it would be very exciting to be the first to demonstrate the value for it, or the first to demonstrate the lack of value for it. And so we can think about how to improve it. Clearly, I have bias. I think it will work, but show me the data. That's what I tell my colleagues. I think when any of my colleagues disagree with me on stuff is because I'm very skeptical about things until I see data. So I know, even though I'm talking positively about AI assistant messaging, I'm also very skeptical and think we need strong evidence to change public health policies or patient care. And but I think this would be the one. I think this is going to be the game changer, and we'll see. We'll see if it makes a difference.
One minor comment here. I think one issue with doing, first of all, I want to see that randomized control trial, and I hope someone gives you a lot of money to actually run it. But one concern might be, this technology is developing very, very quickly, and you could imagine GPT-4 not doing that well compared to GPT-6, and knowing when you do the study, when that money should go in to actually fund it, might be the difference between the faster implementation of something that works and a much slower one. Because a negative trial with an earlier technology that isn't quite up to snuff might actually make people less likely to fund this with future ones. Just a thought.
Well, yeah, no, that is certainly an acceptable thought. I think, clearly there's going to be improvements in this technology going forward. I think also, last week, there was that leaked memo from Google talking about large language models. And, I work closely with a lot of computer scientists. I've hired some computer scientists to transition and work in medicine. Clearly, a lot of people are kind of throwing their hands up who are working on language generation or large language models. They're kind of like, oh, that's the solution, more data. You got a lot of data and a lot of parameters. Fine-tuning doesn't work. And it turns out that assessment was incorrect. There's now a lot of research showing technologies like GPT-4 All, I think came out of Nomic AI. That was a student of one of my colleagues, frequent colleagues, Mark Dresden, one of his students created. And, they can have a large language model operate within your browser. No compute cost. It's within your browser and can read everything you're doing on your browser. And it's not ChatGPT. It's a unique large language model. Everybody came out with guns blazing. Bloomberg GPT, which another one of my colleagues created, for Bloomberg LP, had 59 billion parameters, because they're kind of like, well, we're going to show you. You got to have a lot of parameters and a lot of data tailored to finance. And it turns out bootstrap people out there working now are showing that, you can do a lot of fine tuning. And I think my prediction here is that's going to be the winner here, is like fine tuning is going to work with healthcare substantially more than just a generic large language model, even if it has fewer parameters.
Excellent. John, thank you so much for joining us on the External Medicine podcast. For people interested in learning more about you and your work, where would you have them go on the internet?
Well, you can find me at UCSD or at johnwayers.com, just johnwayers.com, AYERS, and you can find me there and catch up with us. And, if you're excited about working in this space, I encourage you to collaborate with us. I'm very lucky that I've got to now work with dozens of students to have their first, JAMA network publication working with us, even though they're students at Harvard or Oxford or, MIT or Stanford. They come to us because, they see we're working on questions that matter. And I encourage other people to, consider the types of questions that we study in their research. I know it's not compelling to the NIH model, and it's not compelling to your dean, but it's compelling because it can make a difference in public health.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution.
If you'd like to support us, subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.